What I was asked to talk to today was the assessment, staging and following of acute and chronic GVHD, and obviously in the very short time span that's a tall order. Thankfully Linda gave you a very nice look at some of these factors that I'm not going to talk about, which is monitoring of delayed effects, although obviously when you're treating a patient with chronic GVHD, given that that therapy goes over several years in some cases, you need to consider also these features down here. I also don't have time to talk about pathophysiology or a detailed look at immunosuppressive therapy beyond initial therapy. So what I'd like to talk about is the diagnosis and staging of acute, the differential diagnosis of acute, because that's important, and I'll share with you some data that comes from our center, recently presented at the last ASH meeting, looking at initial therapy. And then in my role as co-chair of the CTN trial that was just mentioned, there is still clearly confusion about how to make an NIH chronic GVHD diagnosis and the scoring of that. So we'll focus on that and hopefully clarify those issues. Now, you're very familiar with the acute manifestations of classic acute GVHD that typically occur within the first 100 days of transplant after an ablative regimen. And you can recognize those by the acute inflammatory signs that you'll see in the skin, the gut, and the liver, caused mainly by cytotoxic lymphocytes and associated cytokine-induced damage. If those same symptoms persist beyond 100 days, then it's simply called late acute GVHD, persistent acute GVHD, or if they've had a period of quiescence and then recurrent acute GVHD symptoms, then recurrent GVHD. On the other hand, if you, in addition to those symptoms, have any classic or so-called diagnostic manifestation of chronic GVHD, it's called overlap syndrome. And that's as simple as it is, and we'll show you some more about that later. So the clinical signs are usually insufficient to establish a diagnosis of acute GVHD when there's isolated organ involvement. So if you have elevated liver enzymes, elevated bilirubin by itself, you really need a biopsy to confirm that if there's nothing else going on. On the other hand, if you've got rash or other or symptoms of the gut temporally associated with engraftment, then that usually makes acute GVHD diagnosis likely, although again, we usually like to get biopsy confirmation. And why is that? Because there are differential diagnoses that we have to consider. I'm not going to belabor the point because those of you that have practiced this are familiar with a lot of them. I would like to draw attention to just a couple that we sometimes forget. So if a patient has had severe mucositis and they've had a lot of narcotic therapy, and then you're tapering that narcotic therapy, sometimes if the therapy is tapered quickly, you can get opiate withdrawal syndrome. That's an important one to remember. Conversely, if they're on a lot of narcotics and they're getting sort of bowel stasis syndrome with fluid accumulations, they can get crampy abdominal pain, you can get this narcotic bowel syndrome. Other causes of abdominal pain that you don't want to forget are pancreatitis, so it's often helpful to draw a lipase or an amylase. And then moving down to the liver enzyme abnormalities, there's all of these manifestations that can occur. A frequent one that we must remember is the cholangitis lentis, when you've got a bacteremia or causes of sort of that cholestatic liver picture. So the Glucksberg staging modified here is shown in the Arabic 0 to 4 numerals on the left-hand column according to the extent of rash, liver abnormalities, and gut symptoms. And I just want to pull out, highlight here that the classification in the acute GVHD setting relies on the height of the bilirubin, whereas I'm sure you're all familiar with the fact that now, particularly when we're using ursodiol prophylaxis for liver, we rarely see that. In fact, at our center, the very severe grades of liver GVHD are only occurring at less than 1 or 2%. And so what we typically see is elevated transaminases, 300, 400, sometimes higher, before we even see an elevation in the bilirubin. So that's not taken into account with this classification, in contrast to the chronic GVHD classification schema that does look at liver enzyme abnormalities. The other syndrome you don't want to forget is the stage 1 upper gut syndrome, just with upper GI symptoms shown here. And then if you have lower GI symptoms, it's basically staged on the volume of the diarrhea. You can divide these numbers by 50 to get a per kilogram dose for children. And then importantly, in the bottom corner, note that the stage 4 gut symptoms make no mention of the volume of diarrhea. So you could have very severe cramping abdominal pain, you could have frank blood, and that would be stage 4 gut. But as I showed you on the previous slide with differential diagnosis, you have to think about other causes of those symptoms. So how do we put that together? So we put together the Arabic staging numbers to get a Roman numeral total overall grade, and this is the consensus grading. And I've color-coded this because in Seattle we've made it more complicated. It's not just 1, 2, 3, 4. And why do we get more complicated? Well, we believe there's clinical relevance to sorting out a particular category of grade 2 GVHD into 2A and 2B. And the 2A patient is one that has less than a liter of diarrhea a day if you're an adult, and no elevation of the bilirubin, so it's less than 2, and less than half of the body surface area of rash. If you have more rash or slightly more bilirubin not exceeding 3, then you would fit into this 2B category. So just remember the color scheme here, and those will come back. So there have been, and so why do we care about this? Randomized prospective studies from the Europeans, the Italians specifically, have shown that going above 2 milligrams per kilogram per day for starting therapy for acute GVHD doesn't show any benefit. That said, there's not been a minimum effective dose that's been identified. At our center, we had a retrospective study, a large number of patients led by Marko Milsarek, published in 2009, and when you treat people with 1 versus 2 milligrams per kilogram for grade 2 GVHD, there wasn't really a lot of downside to using 1 milligram per kilogram in terms of non-relapse mortality, relapse, and overall survival that were all similar. There were lower fungal infections in the 1 milligram per kilogram group. One could critique this study, A, because it's retrospective, and B, because there were only a relatively small proportion of grade 3, 4 patients in this analysis. And so you couldn't definitively conclude that for a grade 3 patient that 1 per kilo is okay. However, what Marko presented at ASH in December was the results of the prospective follow-on trial to test whether, again, there was a reduction in prednisone dose if you started at 1 per kilo or 2 per kilo for the severe grades of GVHD. And as shown here on this slide, we stratified into stratified the milder forms of GVHD, the so-called 2As that I was telling you about. Could you even go lower? So they were randomized to 1 versus half. And this study was powered, I can't get into all of that detail now because there's not enough time. You'll have to take my word for it, but it was adequately powered for the endpoint that we chose. And what is an important caveat is that in this lower dose strata, almost all of the patients in Seattle get topical gut steroids, budesonide and beclomethasone. And in the more severe grades of GVHD where they got the higher dose randomization, about half of them got B&B. So this is what we found. After 6 weeks of that therapy, the total prednisone dose at 6 weeks did not significantly differ among the high dose and lower dose strata. And you can say for the patients that mainly have that upper gut syndrome, less than a liter of diarrhea, less than total body surface area rash of 50%, at the end of the day at 6 weeks, there was a trend, but not statistically significantly so, that there was lower prednisone exposure in the people that started with half. And you can see that the 1 per kilo is tapered fairly rapidly. Now, in the 2 versus 1 group, there was even less difference in the dose, and the 2 per kilo groups tapered even more rapidly. And I think what this shows us is that despite designing the randomized controlled trial, the people at our institution were informed by the retrospective study, knowing that we could mostly get away with 1 per kilo. So if a patient was randomized to 2 per kilo, they thought, we can taper quickly. And that clearly seemed to be the case, because what I could show you on these next slides is, again, despite those randomizations, no difference in non-relapse mortality, relapse, chronic GVHD incidence, or survival. So the study didn't meet its primary endpoint, but on the other hand, there was no downside to starting at lower doses. So the conclusions then, what I haven't shown you here is if you started at a lower dose of prednisone, it really didn't influence the survival rate, influence the rate of progression from grade 2A or 2B to the more severe grades of acute GVHD. And the need for secondary systemic therapy was not significantly different in the grade 2A patients, Whereas if you were more severe at onset, the grade 2Bs to 4s, if you started at 1 per kilo, there was a higher rate that was significant for needing secondary systemic therapy. And so you can conclude then that 0.5 milligram per kilogram per SAFO is safe and effective for the grade 2As. What's interesting then, if you again look into the 1 per kilo versus 2 per kilo group, if you started at 1 per kilo and you had the more severe grade of GVHD, it was generally the skin manifestations rather than the gut manifestations that were associated with a need for more secondary therapy. This study also made quite a good look at steroid toxicities. There was no difference among them between the lower dose and the higher dose strata, but it's important to note that there wasn't a large difference in the total exposure of prednisone after 6 weeks. So how do we use this information? Well, I would like to propose to you that for the mild grade 1 patients, systemic therapy is rarely needed. For the moderate 2A patient with that upper gut syndrome, it's okay to start at 0.5 milligram per kilogram plus topical gut steroids. And these pie charts here show you that for the related donors and for the unrelated donors respectively, that accounts for just a little over a third of the patients and a little under a third of the patients for the unrelateds. If you have the more severe GVHD without a lot of body rash, less than half the body surface area, then we would recommend starting at 1 per kilo. Conversely, if you've got more extensive rash, then consider 2 per kilo. And again, reminding you the caveat that Seattle uses topical gut steroids for almost all of the grade 2A patients and about half of the more severe grades. So that's the whirlwind take-home messages for acute GVHD. I want to move on to chronic GVHD, which is the major determinant of late post-transplant allotransplant morbidity and non-relapse mortality. I also want to remind you, because I think it's helpful when you're considering your patients, where they are from transplant, because half of the patients have developed their chronic GVHD by 6 months post-transplant, and only 10% of them develop it beyond 1 year. So that's an important thing for you to recall. And it doesn't tend to matter whether you've had a related or unrelated donor shown by the pink and blue curves. This is the Venn diagram that will either help you or bother you. It depends on whether you like Venn diagrams. But basically the way I like to think of it is, if you think of that big oval here, which basically includes all the acute GVHD manifestations that I mentioned at the beginning, and the darker oval here, which has only the diagnostic manifestations of chronic GVHD, then where they intersect is the overlap syndrome. There's no mention of time in this equation about chronic GVHD, which theoretically means you could have chronic GVHD at day 50 if you have diagnostic manifestations. In practice, does that happen? Rarely. On the other hand, we know that late acute GVHD does happen beyond day 100, and that's why we made it more complicated, because we couldn't just go on with the advent of reduced intensity regimens and just keep saying that late acute was everything before day 100. So from the consensus conference, with the publication in 2005, you need one diagnostic manifestation to call something chronic GVHD without needing a biopsy, or at least one distinctive manifestation confirmed by a pertinent biopsy or other relevant tests in the same or another organ. So that's kind of where it starts to get confusing. And you need to exclude other possible diagnoses. What I want to remind you is that the NIH consensus group is reconvening, has been doing so for the last few months in conference calls, and we're going to all meet in June, and so be prepared for some revisions to these guidelines. So just to quickly talk about history, when a patient comes for a chronic GVHD clinic, I always like to run through these symptoms because it's a quick screening tool. There are more detailed questions in the reference below on the slide, but you want to ask about skin symptoms as shown here. Whether the patient's lost hair, that's an important one. Do the nails look odd? All manner of eye symptoms. So we all know about dry eyes, painful eyes. You need to remember also excessive tearing. So if you're not making enough mucinous tears, sometimes there's an overcompensation with the aqueous tears. So that's an important one to ask about as well. Symptoms in the mouth, esophagus, a little zoning in of detail there. Not just do they have difficulty swallowing or is it painful with the odonophagia, but what causes that? Is it dry foods? Is it the size of their pills? Is it the liquid? Is it progressive? All of those things kind of move you along the way to thinking, do they have a stricture or a web? and the like. So the lungs, you want to ask about dyspnea, wheeze, and whether the dyspnea occurs at rest or on exertion. That can creep up insidiously, as I'll talk about later in the talk. Gut symptoms are pretty self-explanatory, and the joint and GU symptoms. So what I want to just talk about here is our now validated screening scale for, we call the PROM. It stands for a photographic range of motion scale. And when I examine a patient, and this little boy here you can see is trying to do the Buddha prayer position, and he's unable to do that as shown down here in normal on the wrist scale. And sometimes in a child, you're not sure whether they're not following the instructions, so it's helpful to grab one hand and see whether you can push back passively, and clearly he's not able to do that. And you can see he's got quite tight contractures at the elbows, and he can't fully extend, although the shoulders is his best range of motion. And so using this quick screening tool, which takes less than 60 seconds, you can then score them on the chart. With, again, 1 being the worst range of motion and 7 for the wrist, elbows, shoulders being the best, normal, and there's a smaller range of scale for the foot. And you can add those scores up. A total score of 25 is fully normal. And if you wanted to read more about how that was validated, there's the reference there. And this is very helpful. We actually photographed patients in Seattle, and this is a woman I saw in the adult clinic who, over the course of time, had perfectly normal wrist movement there and became progressively tighter, as shown here. And the scale is very sensitive to worsening, but it is also sensitive to improvement. And this is a young boy who, at his long-term follow-up, had tightening here, and just after 1 month of therapy, you can see there's been a slight improvement. So it works in both directions. So in this prospective consortium study of the Chronic GVHD Consensus Consortium you've got here, if you go over to your clinic at any time, the prevalence is going to be 29%. So almost 30% of your patients will have joint limitations if you screen them in the way I just showed you. Most of that abnormality is mild, about 2/3 of them, and most of the action is in the wrists and fingers. So the most sensitive site is there, but you can also get involvement of the elbows, shoulders. Ankles, I find, is always a little tricky because you don't know whether it's limited by vincristine or other things that the patient has been given. But I would encourage you to try this tool. So the diagnostic signs of chronic GVHD are shown here by the check marks, and I'll show you some pictures of those. Basically, if you see those signs, that clinches the diagnosis of chronic GVHD, and you can move right on without doing a biopsy. On the other hand, here are our acute manifestations, and so they're called common to both acute and chronic. So because you can see them in the overlap syndrome as well, they're not sufficient to make the diagnosis of chronic GVHD. So a patient with these symptoms either has chronic GVHD over the overlap syndrome, if you've otherwise made the diagnosis of chronic GVHD, or if you haven't been able to make the diagnosis of chronic GVHD, then it's late acute. The ones in the middle are the distinctive manifestations, and you need a biopsy with the current classification schema to confirm the chronic GVHD diagnosis. And all of these lists are in the Filipovich paper 2005 that I referred to in the earlier slide. I want to just draw your attention to the GI tract. The only classic manifestation is in the esophagus in the form of webs, strictures, or stenoses. So those screening questions are important to screen for that. The other one that causes a lot of problems is what I call the liver conundrum, because even a biopsy can't distinguish acute from chronic. And since there are no diagnostic and distinct manifestations, only these liver enzyme abnormalities, that often is a cause for consternation, and it's pretty hard to say that the liver is involved in isolation with chronic GVHD. And at the bottom you can see the joint changes, the fasciitis are part of classic screening. So what are some of these diagnostic skin lesions? These are lichen planus-like lesions. I'm going to whip through these because you can all see it on the video, but the lichen planus lesions are these sort of papular, violaceous lesions here, but they're sometimes not violaceous. They can be more pale off-white colors, and they don't necessarily have this dark center. You can see them here on the neck, and you can see them on the foreskin of the penis here. This is the patient I showed you with the joint manifestations earlier, and you can see we've demarcated with an outliner just for this visit for follow-up the areas of morphia. So there's very shiny skin. I think you can appreciate it even on the monitor there. These other areas, it's a little hard to appreciate, but you can certainly, if you change position, you can see the changes in the texture. And we've been following these over time, and then the next time you see the patient, you can really have a detailed look at whether they're progressing. This is some now down near the lower back that we've been following, and it's quite firm and hard to move. So that brings me to the next point. You look at the skin, but you also
After the oral exam, move directly to the skin exam with the patient in the same seated position.
Let this play for a bit.
Start with the hands, looking, feeling, and moving. In this case, I could palpate thickening of the deeper tissues of the forearms. It is necessary to define the extent of this abnormality relative to the body area that you are examining. Here, deep sclerosis was evident halfway up the forearms. Look for dimpling or groove signs, which are also indicative of deep sclerosis. Palpate the facial and neck strap muscles, which may also become tight. Proceed in an orderly manner to examine the entire body surface. Ask the patient to lie prone and cover the legs while examining the back. Do not forget to expose the buttocks. Sclerosis may be seen at the base of the spine down to the natal cleft. Now cover the back and buttocks and examine the posterior aspects of the lower legs. Examine next in the supine position, cover the chest and abdomen, and expose the anterior legs. Once again, look, feel, and move all body areas examined.
So you get the idea. That clip takes 2 minutes. Now, obviously, I haven't seen you haven't. There's a little bit of extra time, maybe another minute repositioning the patient. But if you add in an extra minute, that's 3 minutes to do that full exam, and I didn't quite show you all of it. But that's what you need to do. And in the video that was designed to test the NIH consensus tool, it talks about Vienna scoring and the NIH scoring, which is quite complicated. We agree, measuring body surface areas and how much of it's exactly thickened and all of that. But clinically, if you're following the patient and you document it however you want to document it in your clinical note, this is a useful way to do it. In Seattle, in practice, we use a modified Rodnan tool. So rather than trying to painstakingly figure out what the total body surface area in each body segment is, we just use those sort of 17 Rodnan segments, foot, lower leg, upper leg, it doesn't really matter. You just have your own segments, basically, and rank them 0 to 3 on whether it moves normally, 0, whether it's hidebound, 3, and then 1 and 2 in between. No matter what you do, if you practice using a tool, you'll get your own intra-observer calibration variability, and you'll be able to follow them better than you do just, by memory. So I would encourage you to use some sort of quasi-objective measure that you can follow in your practice over time. The important thing just to mention here is sometimes the skin surface moves easily and feels normal, but the deeper tissues are taut. So if you're just looking at the patient and you don't feel them, you'll miss deep sclerosis. That's a key point. The cumulative incidence of this sclerotic GVHD is not trivial, so that's why I'm focusing on these details, because in this series of almost 1,000 patients in Seattle, it was almost 20% at 3 years. Now, this is a severe case here with ulceration. It's very shiny, and you can see on this other patient with rippled and dimpled skin, forearm and upper arm. Those are more severe cases, but all forms, mild to severe, it's about 20% at 3 years. So moving on to the distinctive manifestations, these are the common ones you see. These papulosquamous plaques shown on the lower leg here, sometimes with a bit of scale, and there's a more extensive patch here on this individual's cheek. So theoretically, you need a biopsy of these to confirm the diagnosis. I wouldn't recommend doing it on the face, but that's a distinctive manifestation. So the oral exam, basically...
Putting the oral exam all together, wearing gloves and with a halogen light in hand, start with the patient sitting towards you. Proceed to examine all relevant oral surfaces and scoring sequentially the extent of erythema, lichenoid lesions, and ulcers using categorical scoring. Eyeball the number of mucocils in the lower labial mucosa plus soft palate. Examine all surfaces of the tongue. For completeness, the gingival mucosal surfaces and hard palate are also inspected, but do not contribute to scoring. Now complete the oral components of Section 2 of the Provider Survey. Assign separate scores for mouth pain and other oral symptoms using the history you gathered earlier.
So basically, and this is again a form of scoring that makes use of the symptoms, and you can score sequentially the degree of erythema, lichenoid changes, ulcers, and mucoceles that you're looking on the exam. And it doesn't take very long. You do want to make sure you use a halogen or an LED light source, otherwise you won't see things so well and sometimes miss them completely. Only the lichenoid lesions are diagnostic, and in this slide that you can see on the lower lip, this is from courtesy of Andy Gilman, you can see very nice lichenoid lesions here, but they can look like that anywhere. This is a normal buccal mucosa, so you want to make sure you know what normal looks like. Not erythematous, and it just looks nice and pink. In contrast to these examples of erythema, lots of redness, again more lichenoid lesions here on the lip, lichenoid lesions on the inside cheek. Here's a big mucocele on the palate, and here on the buccal mucosa, very angry and red. This is a pseudomembranous ulcer. Sometimes it looks a bit more yellow than that, but that's like the pseudomembrane over the ulcerated skin. So moving on, this is a list of other manifestations. I want to focus a little bit more on the GI tract and lung, but I don't have time to talk about these other more uncommon manifestations, but you need to be thinking of them. So the GI tract, the classical wasting syndrome that was frequent back in the few decades ago is really mostly quite uncommon now, unless the GVHD is just really difficult to control. The late acute GVHD symptoms are important to remember, and again, temporal relationships are usually very helpful. Had the patient just tapered off immunosuppression and had a flare of diarrhea. You must rule out infections. C. difficile, toxin, positive diarrhea is an important one. Viral problems and other infections you need to look for. So knowing what the pre-transplant sero status for CMV and other viruses is important. Medication side effects is another important one. Are they getting a lot of oral magnesium supplementation? Are they on a high dose of mycophenolate mofetil? And I'd already talked about narcotic withdrawal. Sometimes you have to remember pancreatic insufficiency, especially if the stools are floaty, associated with a lot of gas, and the exocrine tests of pancreatic insufficiency are not that great. So if you send off stool for fat, if you send off fecal elastase test, even if they're negative, if you still don't have a good explanation for the diarrhea and you've ruled out infection, empiric trial of pancreatic enzymes is not unreasonable. Lactose intolerance is something else you can think about. Using lactate products might help. Esophageal web, and we already talked about that. So the lung manifestations, the only diagnostic manifestation of chronic GVHD is biopsy-proven bronchiolitis obliterans. Now that may or may not change with the updated recommendations, but right now it's not diagnostic unless you have a biopsy. It's important to remember that early bronchiolitis obliterans may be asymptomatic, and that in advanced cases you can get air escape, pneumothorax or mediastinum. You've got to exclude infection. So on the other hand, restrictive lung function abnormalities may be related to chest wall sclerosis, so the patient becomes encased in their thorax essentially and can't expand as well. Myopathy from steroids or other causes. For example, you might get a very severe myopathy acutely from statin therapy. And then what we used to call BOOP, and it's now being called cryptogenic organizing pneumonia, that is a common feature not specific to GVHD and historically has usually required a lung biopsy to be sure. But I have to tell you, with improved diagnostic testing, with BALs, and we're not really doing so many lung biopsies for that now. So bronchiolitis obliterans, basically here's some classic spirometry. We've got a very low FEV1, 38% are predicted, and a very low FEV1 FVC ratio, less than 70%, it's 48 here. And that's accompanied by air trapping, shown by a residual volume, which is more than 120% predicted. And if you get that pattern, that's pretty classic for bronchiolitis obliterans. And if you move from there, you would go on and do a high-resolution CT scan with inspiration and expiration cuts. and knowing that if you expire and exhale all the gas, it should be a lot more white appearing, but it's not because there's air trapping. And so you'll see air trapping, and there'll sometimes be a report of ground glass or classifications as well. So that would be enough. That would be a distinctive diagnosis, bronchiolitis obliterans, which would be a distinctive manifestation with these pulmonary function tests and CT findings, and you could call this chronic GVHD if you had GVHD, chronic GVHD, otherwise diagnosed in another organ. I think that may change with the consensus criteria. We'll have to wait for the June meeting. Cryptogenic organizing pneumonia, basically, it looks like an infiltrate, and they can be multifocal, very severe in this case on this CT scan, or they can be unifocal or monofocal. And what you tend to get here, particularly with the more extensive lesions, is a restrictive PFT physiology with both the FEV1, FVC declining and preservation of the FEV1, FVC ratio because they're both declining similarly. The total lung capacity will be down, and there's no hint of air trapping, as you can see in the residual volume. Diffusing capacity is variably down. So distinguishing them clinically, symptoms with bronchiolitis obliterans, you're just going to screen patients for cough, wheeze, dyspnea, often asymptomatic in the early stages because you've got a lot of lung reserve. With the cough, often it's more symptoms of pneumonia. You can have fever, dry cough, dyspnea, not so much wheeze. With the blue highlighted figures here are the key hallmarks of air trapping on the CT scan with inspiration and expiration cuts, so you're going to see air trapping with the expiratory films. And then the FEV1 is going to be less than 75% predicted, or importantly, and this is really important, or a 10% decline from a pre-transplant baseline. So this is recognized to catch those patients who started with, say, 120% predicted FEV1, and they've dropped to 105%. And you say, oh, this is a normal PFT, but it's dropped by a lot. So that's an important thing to remember. And then the ratio that will accompany that lower FEV1 or 10% decline will start becoming obstructive. And then air trapping will be seen here. The prognosis in BO is worse than it is for COP because these patients are usually not so steroid responsive, whereas the other patients tend to respond to higher dose steroids. And lastly, there are studies underway looking at whether we can treat bronchiolitis obliterans with just inhaled therapy, fluticasone, azithromycin, montelukast, and in more severe cases, you're really committed to give higher dose steroids. With COP, starting at a daily steroid dose of somewhere between 3/4 and 1 milligram per kilogram per day and tapering off over 3 to 6 months is usually effective, although flare-ups do occur. If you get either of these conditions, I would propose to monitor the patient monthly times 3 so you can figure out what the trajectory of this response is, particularly if you've elected in the BO cases not to add systemic steroids. You don't want to use mild therapy and have them inexorably decline and not see them for a repeat set of PFTs 3 months later. So you want to make sure it's not going down quickly, in which case you'd be compelled, in my opinion, to add prednisone. Last couple of slides are just looking at the NIH scoring, and I'm not going to belabor the point, but you know that it's a 0 to 3 score based on symptoms in each organ and how they relate to activities of daily living. One of the important things, though, that I want to draw to your attention is that these symptoms in the current NIH classification do not have an attribution assigned. So if you have a score, if you have dyspnea at rest, it's not automatically saying you have bronchiolitis obliterans, but that would be scored as such. And hence, in the prospective consensus consortium study, there was about a 50 to 60% incidence of lung involvement by the scoring system. And we know that's not true because the incidence of bronchiolitis obliterans is more like 10 or 15%. And for all comers, it's a little higher if you've got chronic GVHD. So what this tells you is that some of those symptoms are ascribed to other things. And if you want to learn more about that, I would recommend going and seeing Sahika's poster from our center tonight to see what some of those other confounding causes are. And you can see that some of the diarrheas and all of those other weight loss and stuff will be due to some other symptoms. In the big scheme of things, it doesn't really change how effective the tool is as a prognostic guide, but we may be able to refine it if we start capturing the attribution when we're scoring these patients. So, for example, you're going to score a 2 because the patient's got an FEV1 of 70, but you're going to say, don't think it's due to GVHD, the patient's been a 10-year smoker, for example. Okay, so I think this is the last slide, but once you've got the individual organ scoring, you combine these to get a global severity score, and that's relevant because that's the thing that relates to prognosis. And mild overall organ score would be a score of no more than 1 in up to 2 organs. A moderate overall score is a score of 1 in 3 or more organs, or mild lung involvement. And so again, you cannot have mild overall score if you've got any lung involvement. And then severe scoring is any organ that scores a 3, or if there's lung involvement of a 2. And then you can use that. Now, the scoring wasn't designed to assign treatment, but you can certainly consider it in that way as a practical tool. If they have mild symptoms, mild overall scoring in just basically 1 or 2 organs, and they don't have high-risk features, meaning they're not thrombocytopenic and they didn't have a higher dose of steroid at the start of their chronic GVHD therapy, you can just watch those patients and don't need to treat them systemically. Whereas any of the other grades, generally speaking, you would add systemic therapy with the caveat that you're weighing up the benefit of the graft versus leukemia, tumor effect versus the risk of delaying your treatment for chronic GVHD. And these these scores do have significance in that they relate to the 2-year non-relapse mortality shown on the left, with the mild scores down the bottom here only showing a 3% non-relapse mortality, whereas up to a third of the patients dying if you have overall severe chronic GVHD. And the inverse of that is shown on the right-hand graphics, with very good survival for the mild forms and about 62% survival at 2 years, for the severe forms. And I'll end there and take any questions in the time we have left. Thank you.
Hi, I'm Kiri Hospodar from Phoenix Children's Hospital. And my question is with regard to screening tests and bronchiolitis obliterans. And specifically, given the fact that bronchiolitis obliterans can be sometimes silent in its presentation, have you found at your institution any benefit with screening more frequently in patients that perhaps present with graft versus host disease in another organ system? Do you screen them more frequently with pulmonary function tests than perhaps another patient with the same risk factors who hasn't exhibited any graft versus host disease yet?
Yeah, we're not at that point in terms of being very data-driven about it, but I think you raise a good point. And for example, we know there is some association with viral infections and then going on to develop some of these lung complications. So, if you have a patient who's just had any viral infection that's involved the lower respiratory tract, I think it would be prudent to get a follow-up set of PFTs, and then if they're abnormal, sort of do the screening monthly times 3, as I suggested. It doesn't have to be the full set of PFTs, just spirometry. Jason Chen, who's a pulmonologist in Seattle several years ago, had a study looking at nasal wash secretion screening for viruses coupled with peak flow monitoring that the patients just entered online into a database, and you could see changes in these patients with the dips with the viral infections. Some have recovered completely, some didn't, and so that kind of gets to that point, but there hasn't been a large enough study that I'm aware of that says that the guidelines can be more concrete than what I just suggested, but it's a good point.
Also a question on BOS. What's the incidence of both restrictive and obstructive pattern in BOS? Do you see those in your patients?
So if you're looking at just airflow obstruction, not necessarily meeting the criteria for bronchiolitis obliterans, if a patient has chronic GVHD, there is a study, I believe Jason was the first author, Jason Chen, that showed it's about 30%. But for true bronchiolitis obliterans...
You mean 30% of overlap of both restrictive and obstructive?
Oh, sorry, I didn't understand the question. You mean mixed picture?
Yes.
I'm not sure what the incidence of the mixed picture is.
But they could be, I guess.
Yeah, you sometimes see those patients, particularly in the ones who have had some sort of infectious process, so they've got a restrictive pattern from that, and then they go on and sort of morph into an obstructive pattern. So they get increasing air trapping, and then their FEV1 is more disproportionately low to their FVC, so then they get an obstructive ratio. But as to the actual incidence of that mixed picture, I can't tell you that.
Okay. Another question I have on the assessment of sclerotic changes, which could be deep and dermal. So what's the relevance of assessment? What's the difference between, for clinical practice or for the treatment between deep and dermal sclerosis?
So another good question. I don't think there's any difference in what we do clinically in terms of the immunosuppressive therapy. Sclerosis is bad, whether it's superficial or deep. What I will say is the superficial forms of the sclerosis tend to respond more easily than the deep forms, particularly once you've got tendon involvement and you've got the joint limitation. That takes an awful lot of time to turn around, and in my experience, immunosuppressive therapy alone is insufficient to return to full function, and really the patients that do get maximal recovery in those fasciitis type manifestations are the ones who aggressively do physical therapy, stretching, yoga. Sometimes in the children we do nocturnal splinting, all of those types of
right. And they can also
activities.
have overlap of both deep and dermal sclerosis.
Yes.
I mean, it's also difficult then to differentiate.
Yeah, I mean, exactly. You can get overlap, and what happens in those overlap cases is sometimes that the superficial, there'll be softening of the superficial skin, but the other tendon fasciitis components are again harder to reverse. But sometimes it's all hard. It's all difficult to treat.
Right, thanks. And then the last question, you pointed to that exocrine insufficiency is the manifestation of late acute GVHD. However, this kind of classic chronic wasting syndrome was considered the chronic GVHD. So to my mind, the exocrine insufficiency is chronic wasting syndrome. That's what we see sometimes in our patients. So you think it's still acute?
Well, I think the problem, I didn't catch all of your question, I'm getting a little bit of echo here, but I think what you're asking is, in the wasting syndrome, why are we calling that late acute and not chronic? Is that the question?
Right, because you presented that exocrine insufficiency is the manifestation of late acute GVHD, and the classic chronic wasting syndrome is kind of...
Actually, I don't think I specified what exocrine was. I think I showed in the differential diagnosis slide of what you needed to consider for gut manifestations, but exocrine pancreatic insufficiency can occur in patients with chronic GVHD. I don't think I feel comfortable saying it's absolutely chronic GVHD, but it's kind of one of those, it certainly is not a diagnostic manifestation, and you just need to think about it. It's not common, but sometimes you have these patients where they're immunosuppressed, all of their other manifestations of GVHD have settled, and then they get these malabsorptive floating stools, and they will respond clinically to pancreatic enzymes. Whether or not you've been able to link that to a low fecal elastase test or high fecal fat may or may not be the case, but that's the extent of the pancreatic exocrine insufficiency. Yes?
Yeah, I was just wondering about your opinion in using photopheresis for chronic versus acute graft-versus-host disease, both of the gut and the skin.
So you're getting into treatment, which is a whole other talk. I mean, I think what you're asking me is photopheresis good for gut GVHD or chronic GVHD? And the answer is it can be an effective modality for both, but is it necessary? Is it the only modality that works for those things? I mean, again, we need carefully designed trials to figure out, when exactly it is the best thing to use. In my own practice, photopheresis is used typically when the other things have not failed. When the other things have failed, I mean. However, for very extensive fasciitis or sclerosis, I might move to that a lot quicker because I think that is an aggressive therapy that is warranted for a very aggressive disease.